Hello, my name is Dr. Faisal Anwar. So this is another case of a cataract surgery. In this video, this is a case of a diabetic cataract. You can see here it's a little bit soft and cheesy cataract. First of all, we will make a entry port into the anterior chamber and put viscoelastic into the anterior chamber. Now we will do capsulorhexis with the help of cystotome. Now we will move the tip into the anti-clockwise fashion to make adequate capsulorhexis. In diabetic cataracts, the capsulorhexis is very important. Small sized capsulorhexis will put you into a trouble. So try avoid making small capsulorhexis. Now I'll make an entry port, side port, side port 1 and side port 2. After making two side ports, I will do hydrodisection. First of all, we will put some water jet into the anterior chamber to remove the gel. Then we will go beneath the anterior capsule and push water to hydrodissect the nucleus from the capsule at multiple points. Now the capsule has separated from the nuclear or epinuclear material. Now again we will put some gel in and try to dial the nucleus. As this is a soft cataract, so will not push so much to dial the nucleus. Now we will take the phaco in. Now the trick in soft cataract surgery is don't be in a rush, make small chunks and try to hold the nucleus where the bulkiest part of this nucleus is present. Now we'll take the other instrument into the anterior chamber and try to hold it. You can see the cortex and the epinucleus in this case is very thick, so we have to wait till we get the bulkiest part to lift the nucleus. Now again I am trying to another place to lift the nucleus. Now this is the third place and the fourth place. You can see then the cataractous material get chewed as I try to hold it. So I have to dial the nucleus, keep making the nucleus weak by trying at the multiple points and keep dialing it. This is the only trick that you can use to excel the soft cataracts or diabetic cataracts. Again I will try to hold it. In this case the phaco power should be less, should be around 60% or 55%. If you will use more phaco power, it will chew the cortical or the nuclear material and you will not be able to hold it. So always keep the power in soft cataract cases 60 or less than 60. Now you can see I have divided the nuclear component into multiple pieces by using the dialer. Now when you have made multiple pieces into the anterior chamber, these pieces will automatically come by vacuum into the phaco tip. You can see all of the pieces have been removed. After removing the pieces, we will try to remove the epinucleus or the thick cortical material. You can see this is a thick sheet and we will not pull it so much. We will try to disengage from the capsule and leave it as such. for the Simcoe cannula to remove the sheet. Now we will use a Simcoe cannula to disengage the remaining sheet. We have to disengage it from the capsule first, then we will make a section. I'll try to go through the side port. It's not located. Now again I will put some gel into the anterior chamber to make the SE deep. I will try to disengage this sheet of thick cortex from its peripheral areas. Always remember that this sheet will not come like a normal cortical material. It will take some effort to remove it. So you have to keep disengaging it from the capsule. Don't pull it, otherwise it will damage the capsule. Now you can see here we are removing the sheet by disengaging it from its capsular areas. You have to be patient in such sheets. Now the epinucleus is almost fused with the cortical material. So once you will remove this sheet, the cortical matter will not be there. You can see I am again disengaging it from its capsular areas. This is the last portion which is engaged. Now I have removed all the sheet from the capsule. Now we will do suction through the Simcoe cannula. The part that is present superiorly at 12 o'clock is adherent with the capsule. If we will pull that part, it can damage the capsule. So we will keep hydrating it with the Simcoe cannula till it gets swelled up and come out or gets disengaged. You can see we are hydrating it again and again to remove this part from the from the capsular area. Now again I am hydrating this portion. The patient is young and type 1 diabetic. So that's why the epinucleus is more adherent. Now you can see it's coming out eventually. We waited for it to come. We didn't pull it out. Now it is easily coming out after disengaging from the superior capsular area. Now you can see all of the cortical and the nuclear epinuclear component has been removed from the eye. We will check for any residual cortical matter. In the end, we will make the wounds or the entry ports clear of any debris or any fibers of the lens matter. Now we will put the gel into the anterior chamber and we will load the lens. This is a foldable intraocular lens that we are loading into the cartridge. Now the lens is loaded. Now we will check the entry wound. As the tip of the injector is a bit wide, so we will check the entry wound, and now we will inject the lens into the bag. Here you can see the lens is folded on its own. Now it is injected into the bag. Now we will guide the lens into the bag. After putting the intraocular lens into the bag, we will remove the viscoelastics from the anterior chamber. The adequate removal of gel or the viscoelastic from the anterior chamber is necessary, as it can cause three problems on the first post-op day. Number one, raised intraocular pressure. Number two, reaction in the anterior chamber. And number three, pupillary membrane formation. The most common complications of the retained gel into the anterior chamber is raised intraocular pressure that can lead to corneal edema. So whenever you note that your cases are suffering from the corneal edema on the first post-op day, always think of gel that is left into the anterior chamber. Thank you very much.